All right, hello. We are going to get started with the second session. Before we jump into cardiology, I want to make two announcements. The first is that the CME, the lecture evaluation forms, need to be filled out at the end of the day at the zoo, after Dr. Ettinger's talk, so that the afternoon presenters can be evaluated. And we will have representatives from the CME office there to collect them somewhere around where Dr. Ettinger will be speaking, near the podium at the Cambodian Pavilion. So we need those filled out so that the participants can be evaluated and for you to get credit. The other point is toward the end, as we conclude the actual clinical cases, I'll make some housekeeping announcements about the zoo trip, so want to listen for those. Right now, it's a privilege to introduce first Dr. Mark Kittleson. Dr. Kittleson is a diplomat of the American College of Veterinary Internal Medicine. He is a professor in the Department of Medicine and Epidemiology at UC Davis School of Veterinary Medicine. And also Dr. Jan Tillish, professor of medicine and executive vice chair in the Department of Medicine here at UCLA. Doctors.
Thank you. I'm Mark Kittleson, and I'm a veterinary cardiologist. You're supposed to say, hello, Mark. I feel with this group I can finally admit it, come out. You can be my support group. You know, what is a veterinary cardiologist? I don't think my mother still understands what a veterinary cardiologist is. It's one of those things when you're in conversation and someone asks you what you do. I'm a veterinary cardiologist. They look at you. Then you say, I put a pacemaker in a dog yesterday. They go, yeah, right. So we are a small group. There are about 200 veterinary cardiologists in the United States, probably 300, 350 in the whole world. There are, I think, 6 or 7 of us here today, so I think we can plan on having a meeting for about an hour afterward and get more CE credit. Our discipline is very similar to human medicine. The one big difference is we see almost no coronary artery disease in dogs and cats. The vast majority of the patients we do see are dogs and cats, but we will see anything with a heart that beats. So we will do iguanas to primates. In the dog and cat realm, the very large proportion of our diseases that we see in dogs is myxomatous mitral valve degeneration, called mitral valve prolapse. In humans, it's a more aggressive disease, commonly in dogs, seen mostly in small breeds of dogs, where if they have a murmur when they're older, probably about 20 to 30% of them will advance on to heart failure. We also see cardiomyopathies. Boxer here gets arrhythmogenic right ventricular cardiomyopathy. Dobermans get dilated cardiomyopathy. And in both of them, within the past 2 years, there have been genetic mutations identified that appear to be causal for these diseases in these 2 breeds. Very breed-specific diseases, obviously. And then we see a smattering of congenital heart diseases. This is a PDA, patent ductus arteriosus here. And we have fun with those, closing PDAs with interventional devices, doing balloon valvuloplasties on pulmonic stenosis and that sort of thing, sorts of things we live for. Cats are a whole different story. 90% of the cat diseases, heart diseases, consist of cardiomyopathies, heart muscle diseases, something going on specifically within the heart muscle. And out of that, 60 to 70% of it probably is hypertrophic cardiomyopathy. Extremely prevalent disease. Study going on over in the UK right now would suggest that maybe there's upwards of 20 to 30% of cats that have some evidence of hypertrophy, thickened left ventricular wall on when they're examined echocardiographically. This is what it looks like. This is a very extreme example. This is a cross-sectional view of a heart from a cat named Teddy. I have a colony of Maine Coon cats that have a heritable form of this disease. Teddy was a member of our colony, but he had an additional genetic or congenital abnormality called genu recurvatum, which essentially meant his stifles, his knees were locked in extension, so he walked like this. And he didn't get along very well in the colony, so he ended up being a housemate of mine and my family. And he died suddenly one morning on our dining room table in front of my youngest daughter. "Mommy, Mommy, Teddy's just fallen over and can't get up." So this is his heart on cross-section. This is all left ventricle sitting in here. Heart, like skeletal muscle, after death commonly undergoes rigor. And so this is essentially a systolic frame on an echocardiogram. The heart is contracted after death, and it's contracted down to the point where the left ventricular cavity is essentially obliterated. Echocardiography is the way that we generally diagnose this disease. This is just showing you an example of a cross-sectional view of a left ventricle from a normal cat. Interventricular septum here, left ventricular free wall, papillary muscles in there, and the left ventricular cavity. And a cat with severe hypertrophic cardiomyopathy, markedly increased thickness to the interventricular septum, and left ventricular free wall, as well as the papillary muscles. So I'm going to present a case. This cat's name is Kizzy, 11-year-old mixed breed female cat that presented to us the day after she got into trouble when the owners noticed that all of a sudden she could no longer use her back legs. They'd come home from work and found her in this condition. Most likely she had been like this all day long, because at the point in time that they saw her, she was no longer in pain, and the disease process that she was going through generally causes acute, severe, debilitating pain initially. On physical exam, the primary abnormality besides the hind limb paralysis was a grade 4 out of 6 holosystolic murmur. We couldn't feel any femoral pulses. Her back legs were cold, and the left leg was worse than the right. The right one was starting to have regain some capabilities. We did blood work. Creatine kinase was massively elevated at 202,000, indicating lots of skeletal muscle breakdown. First took a set of thoracic radiographs on her. Essentially what we're seeing here, this is a dorsoventral view looking at the heart. Diaphragm is down here, head is up there, and this is abnormal in that we have a very large left auricle. And this is a lateral view, again, head up there, diaphragm there, thoracic cavity. And here we have the heart, the ventricles down here. Looks like a cone down here with ice cream sitting on top, which is the large left atrium. Now, what she had was a systemic thromboembolus. This is a somewhat common complication to the different types of cardiomyopathies that we see in cats. A lot of them occur in cats that have a very large left atrium. And this is showing where the clot forms over here in the left auricle. Why does it form over there in cats? Primary reason probably is blood flow stasis. This is just showing blood flow in a tube. When blood flow is going at a normal velocity in a tube, everything is fine. When it slows down, quite remarkably, you start getting red cells aggregating. So red cell aggregation occurs there. And of course, this is 0. This is at time of death, everything clots. So in a very large left atrium, you're going to have stasis of blood flow in that chamber because of its increase in size. And the left auricle, that useless appendage that sits on the heart out there, is the region where you have the most stasis and where the clot forms. However, it's not just that in cats, because we can see this occur in cats that have no heart disease. So the other portion of this I like to say is cats like to clot or love to clot. They have special platelets. You look at their platelets sideways in the lab and they aggregate. They go crazy. So cats are special with regard to this situation. Dogs, we can see the same sort of hemodynamic abnormality with no clot formation. So this is not Kizzy, but this is another cat showing you presentation with the rear limb paralysis. And this is showing The clot itself, the thrombus sitting at the terminal aorta, is very large, so once it goes out of the left atrium into the left ventricle and gets pumped out into the systemic circulation, it's so large that it cannot take any sort of branch off there, so it goes all the way down to the terminal aorta, lodges there, and obviously interrupts blood supply to the rear limbs. Next thing we did with Kizzy was echocardiography. So this is a cross-sectional view of her left ventricle. Again, her interventricular septum is here. It is very thick. Left ventricular free wall is very thick. Everything is thick all the way around. Massively hypertrophied papillary muscles sitting in there. And at end systole, she is almost obliterating her cavity, almost contracting down to nothing, as I showed you before in the post-mortem specimen. This is her left atrium. This is a cross-sectional view up at the base of the heart. So we have the aorta sitting in the center here, the body of the left atrium, and the left auricle. Normally, you should be able to do the cookie cutter method, cut out the aorta in your mind, and start putting aortas into the left atrium. In a normal left atrium, you should be able to fit about 3 aortas in there. In Kizzy, you can fit about 10 or 12 of them in there, so markedly enlarged left atrium. No clot in the left auricle. Well, duh, it already left. It's gone. She had a loud heart murmur, so we went searching for the origin of her heart murmur. And she had one of these cool sorts of things that cardiologists live for. This is called systolic anterior motion of the mitral valve, or SAM. And SAM, whoa, everything just slowed down. Cool. Thank you, Microsoft. This is a longitudinal view. Big left atrium up here again, interventricular septum, left ventricular free wall, anterior or septal leaflet of the mitral valve there, posterior or mirror leaflet of the mitral valve down there. Aorta is in here. We can just see bits of the aortic valve cusps there, and left ventricular outflow tract, where blood is being pumped from the left ventricular chamber out into the aorta, is right in through here. And compliments of Microsoft, we can actually see the systolic anterior motion of the mitral valve occurring right here in slow motion. So right in here, if you still have to follow it fairly quickly, you can see a portion of the mitral valve flipping up and actually hitting the interventricular septum here each time the heart contracts. Why is that occurring? It's because this large papillary muscle is pulling a portion of this anterior leaf of the mitral valve into this position up against the interventricular septum. I didn't anticipate doing that for us. Now here's a close-up view in real time. Veterinary cardiologists rock. We have to look at this at rates of 180. Here's just a frame by frame showing you what's going on. This is the anterior leaflet. This is the posterior leaflet. This is in diastole. Next frame, early systole starting to close. Here they are fully closed, and we've got a wide open left ventricular outflow tract through here. We can see a head of a papillary muscle right there, cord coming up to the mitral valve. Everything is fine at that stage. Next frame, this cord is sitting right here, pulling this portion of the leaflet into the outflow tract, creating a narrowed region through there. And then 2 frames after that, it goes all the way up and touches the interventricular septum, essentially occluding flow through there. So again, one more time in real time, systolic anterior motion of the mitral valve. And then looking at it with color flow Doppler, what we're seeing is a bilobed jet, 2 jets. We're seeing one jet starting here and going out toward the aorta, and one jet starting at the same spot going back into the left atrium. This jet is being caused by what's called dynamic subaortic stenosis. So it's that region of narrowing that's being created by that abnormal motion of the mitral valve in systole. And because a portion of the mitral valve is being pulled out of position, it allows a leak in the mitral valve, and so we have mitral regurgitation. So we have two high-velocity turbulent jets just causing Kizzy's heart murmur. And I was just doodling around the web and happened across this. This is a color flow Doppler from a human with systolic anterior motion of the mitral valve. Obviously slower, but otherwise looks identical. One jet out there, one jet going back there. I just got this off the web. No, they didn't make T-shirts. We have tried lots of different things for trying to get rid of these thrombi, and essentially at this stage of the game, nothing works as well as tincture of time. About 50% of cats will break down their own clots. If they have a good enough thrombolytic system and the clot is small enough, they will break down their own clot and get better over time. Obviously, the other 50% don't. We've tried thrombolytic agents, we've tried rheolytic thrombectomy, we've tried surgery, and none of them seem to do any better than just leaving them alone and letting them do their own thing. So that's what was done with Kizzy. He was also treated with an anticoagulant, clopidogrel, and within 3 days when she returned to us, she was using her right pelvic limb normally, but the left pelvic limb was still paralyzed and cold. Sent home again and told to come back for a recheck, but you know how those things go. And she was essentially lost to follow-up after that point. But I did call the owners up about a year later to find out what had happened to Kizzy, and she was euthanized about 5 weeks later because she had a recurrence of the same thing. Obviously, the Plavix did not work. She developed another thrombus in her left atrium, and so they actually witnessed this event. She had an acute onset of paralysis. She was in a lot of pain at that phase. She was also in respiratory distress, so she'd probably also gone into heart failure at that stage, and she was euthanized. Okay, Jan, are you waiting in the wings?
Thank you, Mark. One of the things that, as I watched this presentation and we thought about it, this is a markedly exaggerated phenotype of hypertrophic cardiomyopathy. And that may, in fact, be one of the advantages of the collaboration between veterinary physicians and human physicians, because of the opportunity of the more rapid evolution sometimes in the animal patient and the findings of such exaggerated degree. The case that I'm going to present to you is somewhat different. Let's see, now, do we want to skip through your slides there? And we can. One of the advantages of running a training program in an academic institution is I always have chief residents who know how to do this. I've never learned. Actually, my first chief resident that I appointed was actually Dr. Barbara Madison Horowitz. And she wasn't bad at doing slides. Fortunately, she had a colleague who was superlative at computers. Now, Barbara is actually one of the masters of computers. So we're going to talk about the human side of hypertrophic cardiomyopathy, a very different case. This is an 88-year-old woman who has 2 years of progressive dyspnea, difficulty breathing with exercise. And this has been progressive from being able to walk on the beach in La Jolla to the point where she is having difficulty crossing a room. Just prior to her presentation to me, she had an episode of a rapid pulse, was diagnosed as having atrial fibrillation. For those of you unfamiliar with that, a chaotic atrial rhythm, often very rapid. And in the circumstances, if you can imagine that heart that Kizzy had, or that type of heart, you can imagine that if you had a very rapid heart rate, there would be great difficulty in trying to fill that stiff muscular ventricle. And so under those circumstances, the patient had a marked drop in cardiac output because of this rapid heart rate in this stiff, underfilled heart, less cardiac flow, and had an episode of near syncope, almost fainted. but felt very lightheaded. She had no prior cardiac history. She'd been a very vigorous woman. She was very highly exercising. She'd never taken any toxic materials into her lungs or the rest of her body. She was extremely active in terms of exercise. She weighed about 90 pounds. She was about 5 foot tall and incredibly fit. She was a sculptor and very successful. She had a 93-year-old sister who was still active, running a psychiatry practice in San Diego and one in New York City, flying back and forth every month. So these were remarkable sisters. She, as I say, never had any dyspnea. Her physical examination, apart from her small size and actually a fairly fit appearance and youthful appearance, she had a blood pressure of 112/50, not particularly remarkable, often seen in elderly patients where their diastolic blood pressure, this number is relatively low because of their non-compliant blood vessels, but usually that is accompanied by a rise in this blood pressure, suggesting some limit in cardiac output. Her pulse, now back into regular rhythm, converted spontaneously, was down to 66, relatively slow, but not excessively slow. And her jugular venous pressure was slightly elevated, suggesting some congestion that had gone over onto the right side so that there was some difficulty filling. Her chest was clear, no evidence of any fluid in her lungs, and her cardiac examination revealed this very muscular, vigorous left ventricular impulse, really bespeaking just from the physical examination that there was high muscularity and thrusting of this ventricle. However, the overall size was not increased. That is, it was not something that exceeded the normal anatomic limits. She had a loud systolic murmur, in contrast to the one shown in the previous patient. This one was more related to the difficulty of flow going across that aortic valve, and therefore was in the middle of systole during the ejection phase when the blood is trying to pass through the aortic outflow tract, and with this hypertrophy interfering and causing turbulence. This radiates up to the neck into the carotids because the turbulent flow is going in that direction. She had no extra sounds suggesting cardiac failure, and surprisingly didn't have a fourth heart sound. And fourth heart sounds are caused by the atrium contracting into the ventricle. And the reason probably is because of the same phenomenon seen in an exaggerated phase in the previous case, where the left atrium has become relatively large and can't generate that force. And so this sound is missing. She had a little bit of edema, again suggesting some fluid retention and congestion. Normal pulses. This Bispherians pulse is a particular double-humped arterial pulse that is sometimes seen in hypertrophic cardiomyopathies with obstruction. She did not have that. Let me touch a little on the pathologic manifestations of the human patient in cardiomyopathy, hypertrophic cardiomyopathy, clarify a little bit of what we know now of the way this disease presents itself and what the pathophysiologic mechanisms might be, with the possibility that these are the same with some subtle differences or some marked differences in animals. Myocardial fiber disarray, meaning instead of the linear pattern that is characteristic of the myofibrils, the muscular contractile elements of heart muscle, which act as a syncytium, a continued, almost a band-like structure, even though they're made up of individual cells, but very ordered, very regulated. This is changed in hypertrophic cardiomyopathy, but to a greater or lesser degree. So some of the fibers are rather disorganized in their structure. Fibrosis, which used to be, even a few years ago, was thought to be an end-stage product of long-term hypertrophic cardiomyopathy, is actually the first sign. And that has been demonstrated by taking populations with known hypertrophic cardiomyopathy genes and looking at them in the proband of the index case in the family, and then the carriers in the family that have that genetic abnormality, and finding out that even before the hypertrophy, you begin to see fibrosis occur, as demonstrated by a biomarker of collagen or fibrous tissue elaboration. Hypertrophy is obviously part of the disease process, but it's surprisingly variable both in the amount and the rate of development, and we'll look at that a little bit more. So the phenotypic expression varies in humans, and I'm sure also in animals. The hypertrophy may be asymmetric, as was demonstrated in the previous case, and I'll show you an example in a human with ASH, with the anterior septal, the asymmetric septal hypertrophy. There may be minimal degrees of hypertrophy, less than 20% of the ventricle. The areas that are hypertrophied vary in human cardiomyopathy, so different locations, and not always the classic asymmetric septal hypertrophy. And it may be rather delayed in onset, and that one wonders how long this 88-year-old woman was developing her cardiomyopathy, developing the hypertrophy. The fiber disarray, that is this disorganization of the way the myofilaments are connected, is independent of the left ventricular hypertrophy. You can have a lot of hypertrophy and little fiber disarray, or a lot of fiber disarray and very little hypertrophy. Again, we were once taught that the actual disorganization of the fibrils resulted in isometric contraction of these, some fibers going this way and some fibers going this way, and when the ventricle pulled, they hypertrophied because they were doing sort of isometric exercise rather than a more normal organized pattern. That turns out not to be the case. These are not connected. They may be minimal amount of fiber disarray, as I mentioned, and rather delayed, and it can be very substantial, where 40% of the left ventricle has it. Fibrosis, again, can be very early, and it can be localized, sometimes only at the base, which is rarely seen in the animal cases when they've looked, insofar as is the cases that I've reviewed. Now, there's another set of abnormalities that may be present that don't fit with this kind of expression of muscle abnormality. One of them is that the mitral valve itself may be elongated. The leaflets are elongated. Some have thought that that may be related to stretching over a long time of the hypertrophy in the papillary muscles pulling on them. But interestingly enough, in some patients well before the hypertrophy, one sees this elongation of the fiber. May actually see the papillary muscle insertion directly into the valve leaflet without the cords that attach the muscle to the leaflet under normal circumstances, and other abnormalities of these cords. This may occur earlier rather than a later finding, suggesting some developmental abnormality. Arrhythmias and conduction of the impulse disturbances are common in human cardiomyopathies. Sudden cardiac death is its most feared concern, particularly in the young, particularly in the exercising young. It is the leading cause of death for death in exercising athletes. But interestingly enough, after the age of 30, although the incidence of sudden cardiac death is greater in patients with hypertrophic cardiomyopathy, the incidence of sudden death is not particularly greater. It is greater than those who have no heart disease, but not hugely. While less than 30, it's a very, very common resolution of this disease, is the death from a rhythm disturbance. Wolff-Parkinson-White syndrome, an abnormal pattern of conduction around the normal delay portion of the cardiac wiring system, conduction system, is also common, again suggesting some form of developmental abnormality, that this may not in fact be a consequence of late fibrosis scarring the conduction system, but may in fact be an abnormality of the conduction system itself. These are 4 common electrocardiographic patterns, another way of looking at the phenotype. This sigmoidal hypertrophic cardiomyopathy means that you can see the hypertrophy of the septum here, and you can see a sort of S shape as one looks at the ventricle. Obviously, it's an elongated shape with most of the hypertrophy here, but a fair amount of hypertrophy here as well. That's a very common abnormality. 40 to 50% of all cardiomyopathies seem to have that pattern on the electrocardiogram. But only 10% of those patients, when investigated, can we find a genetic abnormality. That means it may be sporadic and not a genetic abnormality, or simply that we have not found the genetic abnormality, and we'll return to that. The reverse curve, this kind of configuration, shows a large bulge in the septum, this asymmetric septal hypertrophy, with very little at the base of the heart here, almost normal, and some hypertrophy there. That is also a fairly common echocardiographic pattern and has a high association with some gene that has to do with a muscle of the ventricle, the so-called sarcomeric. A sarcomere is the element of conduction within the heart cardiac cell, or myofibrillar or myofilamentous abnormality. So this is the most common one with a genetic abnormality. We'll touch on some of those variances. Apical hypertrophic cardiomyopathy, largely confined to this region, is fairly uncommon as an echocardiographic pattern, but has a moderate number of those patients will have some genetic abnormality. And then this generalized cardiomyopathy, so-called concentric, is also fairly uncommon, but with a fair incidence of gene involvement. So one of the ways to look at the patient is how they present. Is that a characteristic? Do they have fibrosis early? Do they have it late? Is that a characteristic that leads us to understand the disease? Another way is looking at the physical presentation as the shape of the heart, its geometry. Is that something unique, and can we begin to investigate how those patients develop this abnormality based on a certain genetic abnormality or genetic pathway? Here is the kind of configuration that one might see in patients with this. You can see the sort of bulging of this interventricular septum, and you've seen before in the cat that marked exaggeration of that. A little bit about the genetic findings. 1 in 500 in the population have hypertrophic cardiomyopathy, so it's a common disease. It's about 1 to 2 in families, suggesting that 50% of the children of an individual with hypertrophic cardiomyopathy will also have it. Therefore, it fits an autosomal dominant expression. There is no marked gender involved dominance. About 60% of patients, a little more now, who have it and have been investigated have some genetic abnormality. The majority involve the heart muscle itself, the portion of this structure. There are some other non-sarcomere abnormalities, things that have to do with calcium handling, things that have to do with connections in the heart that are separate from the heart muscle itself. And there are a number of cogenetic multipliers, other genetic abnormalities that seem to make this worse. 2 genetic abnormalities that are characterized, the two most common ones that I'll refer to. If they occur together, the disease is more severe and more early expressed. But you may have one of those abnormalities and then some non-sarcomeric abnormality. This is the renin-angiotensin-aldosterone system. We now know that angiotensin, which is a blood vessel constricting substance, has marked growth promotion in a pathologic way, and it does induce fibrosis. And the aldosterone stimulated by the angiotensin release is a substance designed to hold on to salt and water, but in fact, largely in this circumstance, is a real villain. It's very much involved in increasing fibrosis and may be a trigger in these patients. This is just a rapid list of some of the genes that have been associated with hypertrophic cardiomyopathy. These are the 2 common ones, the beta-myosin heavy chain, and I think Mark will talk a little bit about that in cats, and the cardiac myosin binding protein C, which is also common in animals. But all these other abnormalities, including some non-sarcomeric ones like a phospholambin gene, which has to do with calcium regulation, may be important as well. The mechanisms of how these genes cause a physiologic abnormality, a pathologic abnormality, is not clear. Some of the possibilities are that there's a gene expression of abnormal proteins, so that these genes are mutated in a way that abnormal proteins are produced that cause fibrosis or fiber disarray. One of them is that there's an abnormal growth promotion, a hyper growth of muscle cells and causing the hypertrophy. These 2 are rather fascinating and have been advanced that suggest the possibility of a developmental abnormality, that the migration of epicardial cells during the development in utero is disturbed such that they don't migrate in the normal pathway into the primitive cardiac tube, and that this may lead to the abnormality of the mitral valve, the abnormality of the conduction system, and that there may be a mechanical deformation of the actual DNA within the nucleus that has been demonstrated in certain experimental animals, or that the mechanics affect the way the genes are transcribed. So an epigenetic phenomenon where the gene is abnormal, but what's really happening is that it's resulting in abnormal expression or repression of genes. Let me just speculate a little before Mark has a chance to talk a little bit about what he's been thinking about in the animal models. We have a potential advantage collaborating with our veterinary colleagues, as has been mentioned earlier, that animal breeding patterns permit some gene constraints, so that the very pattern of developing an animal, a dog, a cat, of particular breeding advantage may also diminish the number of potential genes and therefore may result in our being able to fish in a smaller pond, if you will, to use an ichthyologic term. There may be more rapid disease expression in animals and thus allow us to see the natural history better. On the human side, we've demonstrated a number of mutations that we can now begin to look at in the animal models and begin to investigate the potential animal variations. And lastly, there's a major benefit to us to understand prognosis, but we need to get to the stage of understanding ways to treat this disease, and that will require us to understand the proteomics of these diseases. That is, what abnormal proteins are being expressed and how that leads to disease and how we can correct that. We've got some other slides.
Hold on a sec. Pay no attention to the man behind the curtain. And I need an AV guy. No, it's not turning on for some reason.
Yes. The chief resident in action.
Okay, I'm going to put Barb's hat on for just a second, and the question is, what has human medicine done for veterinary medicine with regard to hypertrophic cardiomyopathy, and what might veterinary medicine be able to do for human medicine in the future? We started our cat colony in about 1992, and in 1989, Cricket Seidman at Harvard found the first mutation that causes hypertrophic cardiomyopathy in humans. It was in the beta-myosin heavy chain gene, and from the very beginning then of our colony, one of our goals was to find out what causes the disease in Maine Coon cats. In addition to what I've shown you already, there are a lot of similarities between the disease in cats and the disease in humans. We talked about the phenotypic similarities, so here is a human with a massively hypertrophied interventricular septum, and a cat that has more global hypertrophy of both walls, but still looking very similar. You can also see this one has a clot sitting right in there. Up until 2005, then, no cause had been identified. In 1998, after we had done selective breedings within our colony over about 6 years, we were able to show that the disease was inherited as an autosomal dominant trait in Maine Coons, just like it is in humans. So that was one more piece of evidence that the cause in cats might be the same as it is in humans. For those of you that don't know what Maine Coons look like, they come from Maine. They're not primary coon cats without the E. They have lynx tips on their ears. They have fuzzy feet like hobbits and big tails. And the boys are usually big and smelly, if they're intact in a research colony. So this is our description of the model of the disease in our colony in 1999, showing that it was an autosomal dominant trait and characterizing the phenotype. As Jan has alluded to already, this is a heritable and genetic disease in humans, again with the first mutation being identified in a sarcomeric gene in 1989. Since that time, there are now over 1,000 different mutations that have been identified that cause this disease. The majority of them are in 10 different genes that encode for sarcomeric proteins. And as he's already said, myosin-binding protein C and beta-myosin heavy chain genes are the predominant ones. Again, there's a lot of phenotypic similarities between the two species. We get thickening of the wall, we get systolic anterior motion of the mitral valve, and in the cats in our colony, the myocardial fiber disarray, the hallmark of the disease in humans, is seen also in all of our cats. This is again just, I picked this out of a paper, and this is out of one of our papers. We both had the same idea. Show the thick heart there, show the myocardial fiber disarray there. They showed small coronary artery disease in human patients, and this is showing the fibrosis that Jan was talking about previously. So because of the similarities, we postulated that Maine Coon cats may also have a sarcomeric gene mutation, and Kate Muirs, who's the only veterinary cardiovascular geneticist in the world, started looking for a mutation in our cats. And after several years, more like 10 years, we finally identified a mutation in the myosin-binding protein C gene at this location. 2 years after that, we identified a similar mutation in a different area of the same gene in Ragdoll cats. So we've got two different mutations now in cats, one that sits up around here in myosin-binding protein C in the very proximal portion there for Maine Coons, and down here in C6 for Ragdolls. This is Kate. Now, this is the paper that we published on Maine Coons, but she's holding a Ragdoll, traitor. And then 2 years later, in genomics, we reported the mutation in Ragdolls. Currently, up at Washington State University and several places in Europe now, we're able to test for those mutations to help breeders take those cats out of their breeding lines, and so they don't propagate the disease. This costs about $60. Similarly, in humans, they look across 18 different genes now for all of these different mutations, $4,000 to $5,000, paid for by insurance. What's different about cats with regard to, in comparison to humans, most humans with the myosin-binding protein C mutations are heterozygous, obviously, for the mutation. As it's been hinted at before, brothers and sisters shouldn't mate in humans, and in cats that's encouraged. So we have mostly heterozygous individuals in humans, but in cats we have a lot of homozygous individuals we're finding. There's a very high prevalence of the mutation in Maine Coon cats. 30 to 35% of the cats that have been tested so far have the mutation, and of those there's about 5 to 10% of the population out there that is homozygous for the mutation. Individuals that are homozygous for the mutation get the disease very early on and get very severe disease in most instances, as you might suspect. So that's what humans have taught us about cats. We've been able to identify a couple of mutations. What can cats teach us about humans? Homozygosity is bad. If you do that sort of breeding, you may end up with this. a six-legged, hairless cat that looks like George Bush. Sleep is good. Cats spend 85% of their life asleep. When we see them in the clinic, obviously they're awake and usually a little fractious. And at that point in time, we commonly see systolic anterior motion of the mitral valve. We're always wondering, should we treat it then? We treat it with a beta blocker to try and tone down the sympathetic nervous system. But the cat's going to go home and go to sleep anyway, and the sympathetic nervous system is going to go to sleep also. So maybe sleep is good. I would like to have had a little bit more this morning. What are we using the colony for now? We have a collaborator on the UCD campus, Samantha Harris, who's looking at this to find out exactly what the mutated protein is doing within the cell. Trying to figure out if we have so-called haploinsufficiency or poison polypeptides produced. Haploinsufficiency essentially means that you have a mutated protein produced that's so strange that it gets destroyed within the cell and never makes it into the sarcomere. Poison polypeptide instead, not so bad, still makes it into the sarcomere, but once it makes it into the sarcomere, probably alters the properties of that sarcomere so that it either contracts better or doesn't contract as well. There's evidence for both in different types of mutations. And then the potential for using this as a model for therapeutic interventions. There's an investigator at Stanford that's interested in doing allelic silencing with hypertrophic cardiomyopathy. In this situation, you essentially turn off the messenger RNA so the mutated protein is never produced. And here is just a little teaser. These are from 3 of our cats from the colony. Dr. Harris has an antibody to normal myosin-binding protein C and another antibody to the mutated form of myosin-binding protein C with the A31P mutation. On top here, this is a normal cat. Green is the immunofluorescence for the antibody against cardiac myosin-binding protein C. Red is just a marker protein myomesin. And so obviously when you stain with the regular antibody in a normal cat, this is what it looks like. This is a cat that's heterozygous for the mutation. Obviously this stains for both the mutated form and the wild type form, so that's the way it should look. And this is a homozygous cat, obviously should look that way also. When we just stain for the mutated protein, this is the normal cat, and obviously there's no mutated protein there, which is appropriate. Here's a heterozygous cat that shows you that the mutated protein is incorporated into the sarcomeres, and the cat that's homozygous has the same thing. So this is a case of poison polypeptide where it's being incorporated into the sarcomere.
Can I grab your microphone for just a second?
Sure.
Well, thank you, Drs. Tillish and Kittleson. I'm going to grab that part. They have done a very good job in discussing the case of hypertrophic cardiomyopathy and introducing some comparative elements. In the interest of staying on the time schedule, I'm going to actually diverge a little bit from the formal way we've been doing it, because I think we had a nice and sort of more detailed conversation about the genetics and some of these aspects. All of our doctors are going to be on the tour. We're encouraging conversation on the bus while you're eating your box lunches, at the zoo, so please, if you're interested, come and talk to Drs. Kittleson and Tillish. But we're going to go ahead and move forward now. So we'll go ahead and thank you very much.